Thank you very much for this kind invitation and opportunity to talk to you today about pain and analgesia in rheumatic diseases. I'm sorry I couldn't be there in person, and I hope perhaps in the future I can join you. These are my disclosures. So before getting started, I wanted to take a step back and talk about chronic pain and why we should care about it. So chronic pain is more prevalent and costly than other common diseases. In the US alone, about 100 million people have chronic pain, and worldwide it's about 1.5 billion people, or 20% of the world's population. And this is important to put into context because this prevalence is higher than cardiovascular disease, diabetes, and cancer combined in the US. And also, the majority of chronic pain are due to rheumatic and musculoskeletal diseases such as osteoarthritis, chronic low back pain, gout, and rheumatoid arthritis. And overall, chronic pain, in this first bar here, is more costly than these other common comorbidities. So, what is pain and why do we experience it? This is a nice schematic from Clifford Wolf from about 10 years ago now. Noxious stimuli such as heat, injuries, chemicals, they are picked up by peripheral nociceptors, and those action potentials go through the dorsal root ganglion into the central nervous system and are experienced as pain. In contrast, innocuous stimuli, such as a light touch of a feather, goes through low threshold mechanical receptors and are experienced as touch. Now, we know in rheumatic diseases, many patients experience hyperalgesia and allodynia. So what does this mean? Well, the blue line here is the normal response to pain with increasing stimuli intensity. So for hyperalgesia, that is feeling more pain with a painful input. So under normal circumstances, you might feel a little bit of pain, but if you have hyperalgesia, you feel a lot of pain for that same stimulus. Similarly, allodynia is experience of pain when the stimulus should not be painful at all. So why does this happen? Well, central sensitization is one of the major mechanisms. So if you have a noxious stimulus, when you have central sensitization, those nociceptors respond to either subthreshold inputs or have an exaggerated response going through to the central nervous system and are experienced as hyperalgesia, or innocuous inputs are, there's like a crosswire and are experienced as allodynia. So how does this relate to our diseases? So I'm going to start with osteoarthritis. As many of you know, there is this so-called structure-symptom discordance in osteoarthritis, such that some people have knee pain, some people have radiographic OA, but the combination of both knee pain and radiographic OA is not complete. And so this has led some people to question what's going on. And if I were there in person, this would have been our polling question. Does this structure-symptom discordance reflect the lack of an important role of pathology in the pain experience in osteoarthritis? Sorry, you're not able to vote on this, but you can think to yourself as to what you think the answer is. Well, in actuality, structural pathology does contribute to symptoms in osteoarthritis. It's just that the typical studies have not been designed to really be able to disentangle pathology from all of the other things that can contribute to the pain experience, such as genetics, BMI, gender differences, psychological factors such as depressive symptoms, catastrophizing, coping skills, etc. And so I took an epidemiologist's approach to this, where I took people who had pain in one knee and no pain in the other. In that way, all of those between person differences would be inherently controlled for. And the only reason for a difference in pain in one knee versus another in an individual must be something going on at that knee. And when you do that kind of analysis, you see a very nice dose-response relationship. So on the x-axis, you have the Kellgren and Lawrence grade, which is the radiographic severity. And on the y-axis is the risk for having pain. I did this study in 2 different cohorts, the multi-center osteoarthritis study and in Framingham. And you can see this nice dose-response relationship with greater structural pathology, having greater risk of pain, even at the earliest stage of radiographic OA at Kellgren and Lawrence grade 2. So the reason that studies have had difficulty disentangling this joint pathology contribution to OA pain is that there are so many other factors that contribute to pain. And clinically, we recognize that psychological factors are particularly important, such as depressive symptoms, poor coping skills, etc. Sleep is another area that we should be addressing when trying to help our patients with pain. But I became interested in neurobiological mechanisms because we have clinical clues that this is really important. For example, in early stages, there's very localized pain, but in later stages, the pain can become much more diffuse and there can be referred pain. So understanding these neurobiological mechanisms is important for understanding where we might find new treatment targets. So this is a very classic depiction of the experience of pain, but pain is not a straight through transmission from the periphery up to the brain. There's complex pathways, including facilitatory and inhibitory pathways, and we can assess these with both experimental pain and clinical pain syndromes. And as a simple schematic, this is a cartoon that I typically use. This is a spinal cord and this is the brain. So from the periphery, you get peripheral nociceptive input that goes up to the dorsal horn of the spinal cord. And then you have ascending facilitatory pain signals. And there's also descending inhibitory modulation. And those inhibitory modulation pathways can dampen the pain signals. So how do you assess neurobiologic mechanisms? Well, this very complicated set of diagrams is indicating that these mechanisms are primarily assessed in animal models using electrophysiology, so interrogating nerves and spinal cord. And of course, we can't do that in humans, even though I've been asked at many pain study meetings as to whether or not I study electrophysiology of the spinal cord, which we cannot do. So clinically, we can use a series of physical modalities that the umbrella term for which is quantitative sensory testing, or QST. These are modalities that can be used in experimental settings to identify pain responses. So we can have punctate probes, cold water baths, pressure, pain threshold, heat, etc. Now, Dr. Phil Mees is going to talk to you about other ways of assessing central pain mechanisms, including questionnaires, and I'm going to focus on these sort of objective measures. Now, how do we know that these things directly relate to what's going on in the central nervous system? Well, one example here is the study where they used heat, and the higher the pain ratings with heat, there was greater brain activity. So this at least shows some correlation between these peripheral modalities and the pain response experienced and what's going on in the brain. So one of the common modalities we use in osteoarthritis study is pressure pain threshold using a handheld ergometer, because mechanical input is thought to be most relevant to this biomechanically driven disease of osteoarthritis. Now, lower values of pressure pain threshold reflect greater sensitization, meaning that if you are applying this ergometer, the sooner the pressure changes to pain is a low pressure pain threshold. And when you assess pressure pain threshold at a diseased site, that indicates peripheral and or central sensitization. That's what you're assessing. When you assess pressure pain threshold at a non-diseased site, this is primarily assessing central sensitization. So in one of the first studies we did with pressure pain threshold, I conducted this in a multi-center osteoarthritis study, which is a cohort of about 3,000 older adults with or at risk of knee osteoarthritis. And we found that the lowest pressure pain thresholds at the knee were associated with the highest risk of having frequent knee pain or more knee pain severity. And this was after adjusting for all potential confounders. Interestingly, we also found a similar pattern at the wrist, where the lowest pressure pain threshold, meaning the most sensitized, had the highest risk of having knee pain, frequent knee pain or knee pain severity when assessing at the wrist. showing that this is kind of a broader systemic effect. Now, there's another modality called temporal summation, and in animal models, this is known as wind-up. This phenomenon occurs in the central nervous system and is a reflection of central sensitization. So when a stimulus is applied, an action potential occurs and a certain level of pain can be elicited. For normal people, this would go back down to normal, and each time you apply the same stimulus, you get the same pain intensity. For someone with temporal summation, these kind of build up on each other and the pain intensity increases over time. So we did this study in the most cohort again, and we used these punctate probes, again, a mechanical input. And again, a normal response is the same amount of pain with each stimulus, whereas if someone is sensitized, they will have temporal summation, meaning their pain will increase over time. And this summarizes a number of different studies that we did in this cohort. First, we were surprised that radiographic knee osteoarthritis was not associated with temporal summation. So radiographic pathology was not driving temporal summation. But instead, we found that symptomatic knee OA and frequent knee pain started to have some associations, and the strongest associations at the knee and the wrist were with knee pain severity. So there's something about temporal summation and pain severity, but not radiographic OA. But we know that radiographs don't pick up all of the different features in osteoarthritis. And so we looked at the MRIs that we had in this cohort. We looked at mechanical lesions, which are bone marrow lesions, and inflammatory lesions, such as synovitis and diffusion. And what we found was that bone marrow lesions were not associated with sensitization, but inflammatory lesions were. So this is starting to put together a picture of inflammation and pain and sensitization. Now, this is Lisa Carlessa, one of my former mentees. We were interested in identifying what factors may be inherent in an individual that predisposes them to developing pain and persistent pain. So we again looked at in the most cohort and identified people who were free of persistent knee pain at baseline. And then we took an agnostic approach, looking at a number of different factors that we think are important for pain, the pain experience. And we performed a latent class analysis. We identified 4 different clusters. What was interesting is that widespread pain, pain catastrophizing, depressive symptoms, and poor sleep, all of which contribute to the pain experience, did not differentiate between these clusters. Instead, the clusters differentiated on the degree of sensitization by pressure pain threshold or temporal summation. We then looked at these people who were free of persistent knee pain at baseline to see which of these clusters had the greatest risk of developing persistent pain 2 years later. And we found that those that were most sensitized by pressure pain threshold had a 2-fold increased risk of developing persistent pain 2 years later. So this has tremendous implications for understanding the transition from acute to chronic pain in osteoarthritis and in many other diseases, and in fact was identified by an NIH pain symposium that year as being one of the most important insights about our understanding of this transition from acute to chronic pain. So I wanted to also share with you some insights we have on sensitization in hand osteoarthritis. And this is work in conjunction with Pernille Steen-Petersen and her mentor, Ida Haugen, with whom I've had a long-standing collaboration. They implemented these, our protocols from the MOST study in the Norhand cohort. And similar to what we found in osteoarthritis, knee osteoarthritis, increased sensitization is associated with increased pain and hand OA. And then looking at radiographs and ultrasound, we found that pressure pain threshold was associated with Kellgren and Lawrence grade and signs of inflammation, and temporal summation was associated with erosive hand OA, again, associated with inflammation. So here again is a link between inflammation, sensitization, and pain. And so speaking of inflammation and pain, rheumatoid arthritis is our prototypical inflammatory arthritis. We know that the cardinal signs of inflammation are rubor, calor, tumor, and dolor. So, is the pain in rheumatoid arthritis solely due to inflammation? We know that cytokines and many of the inflammatory mediators can interact with nociceptors and contribute to the pain experience. So, if I were there in person, this would be our second polling question. Does pain in rheumatoid arthritis primarily reflect inflammation? Well, the answer is mixed. So I don't expect you to get all the details here, so I'll just walk you through this. This is a study by Georg Schecht's group from over 10 years ago now, where they took a small group of people with rheumatoid arthritis, about 14 patients, who were given infliximab. And what they found is that their VAS pain decreased before swollen joint count, tender joint count, and DAS28. In fact, their pain decreased on day one. Whereas swollen joint, tender joint, DAS28, it took a few weeks before those parameters decreased. In contrast, signals in the brain in pain areas also decreased by day one, coinciding with a decrease in their VAS pain. So they concluded that the TNF inhibitor infliximab affects the CNS activity before systemic anti-inflammatory effects. So certainly some of the pain can be, in rheumatoid arthritis, can be ascribed to inflammation. However, we know that that is not the full picture. And this has important therapeutic implications because we obviously use a treat to target strategy in managing rheumatoid arthritis, and disease activity drives our treatment decisions. So this assumes that pain is solely related to RA pathology. But as you know, there is this concept of fibromyalgia in rheumatoid arthritis, and certainly fibromyalgia can be comorbid in rheumatoid arthritis. So this has important implications for when we're pushing a treat-to-target approach, escalating immunosuppressive therapy, when some of that pain may not be solely due to disease pathology and inflammation. And I imagine Dr. Mies may be addressing some of these issues. So I wanted to share with you some work that I've had the pleasure of doing with Dr. Yvonne Lee, who's now at Northwestern, which she started when she was still in Boston, and her mentee, Andrew Heisler. So we used some of the same protocols that I've already shared with you, pressure pain threshold and temporal summation. And we found that those who have more sensitization had greater pain severity, even after accounting for inflammatory measures. So lower pressure pain threshold and higher temporal summation, both indicating more sensitization, had greater pain ratings. In addition, we looked at pain sensitization and disease activity, and we found that measures of pain sensitization were associated with tender joint count and patient global, as well as overall disease activity indices, driven primarily, not surprisingly, by tender joint count and patient global. We also looked at sensitization measures and the impact on response to treatment in rheumatoid arthritis. We found that sensitization was associated with lower rates of good EULAR response. So the orange bars indicate those that have the most sensitization by different measures, and they had a lower likelihood or lower prevalence of having a good response. And if you had more than one type of sensitization measure, you had the lowest prevalence of having a good EULAR response. And so I don't have any studies to show you of gout, but I would like to just raise this as a thought as we are nearing the end here, that the prototypical rheumatic disease that exhibits sensitization is gout. If you think about it, this is a disease where during flares, the joint is exquisitely tender, even beyond the joints, such as the skin, the classic description of not even being able to have the bed sheet touch the skin. So that is a prime example of sensitization, and yet it resolves spontaneously. So if we could harness our understanding of how gout becomes so sensitized, joints with gout flares become so sensitized and then spontaneously resolve, we would have new avenues for addressing pain if we could understand those pathways and develop targets. So what's new for managing pain? Well, I think there's a lot going on that we as rheumatologists will need to come up to speed on. I think eventually we as rheumatologists are going to have to think beyond the joint and think about what's happening at the peripheral nociceptors, coming up to the dorsal root ganglion, the spinal cord, and the brain. There are already some treatments that we use that affect these pathways, such as NSAIDs, opioids, SNRIs, but these are usually not in the prime purview of rheumatologists. So there are a number of emerging pain targets, for example, at the periphery, on the peripheral nociceptor side of things. Nerve growth factor has obviously been one of the most important discoveries with promise for osteoarthritis in particular. And then TRPV1 I highlight here because it was recently in the news, if you will remember, that Dr. David Julius received the Nobel Prize for discovering the TRPV1 receptor. And we use capsaicin, which binds TRPV1, as a topical treatment in osteoarthritis. CGRP has not moved forward for osteoarthritis, but is licensed as an anti-migraine agent. And anecdotally, some of my patients have told me that their MSK pain has improved after they got started on it for their migraines. And there are a number of other receptors that are being developed and tested. And they're in rheumatic diseases, with the focus primarily in osteoarthritis. A number are in trials for osteoarthritis. I won't go into all of these, but unfortunately, our most promising one, NGF, has hit a snag in that Lilly and Pfizer have stopped development of tanezumab, and so it's unclear where this is going to go, and that this is a topic for another talk about the joint safety concerns about NGF. But in any case, I want to just highlight what are the consequences of not being careful enough with managing pain. So we know that nociceptive pain is needed to prevent harm. And we know what happens when you have an insensate joint. You can get a Charcot joint. So first, we want to make sure that patients understand that zero pain is not the goal, because physiologic pain is needed for joint protection. Instead, we're trying to manage their pain so that they can have good function and good quality of life. On the other hand, there are unintended consequences of not having adequate pain management options. And this is one of my former mentees, Andrew Stokes. We used NHANES data and looked at prescription medications for people with arthritis from 1991 to 2015. We looked at prescription opioids and prescription non-narcotic analgesics, which is primarily NSAIDs and COX-2 inhibitors. And you can see that after a certain point in time, there was a steep, marked drop in the prescription of NSAIDs and COX-2 inhibitors, coinciding with an increase in opioids. And that occurred around 2004, where, for those of you who've been in medicine long enough, you'll recognize that was when Vioxx came off the market. So as the risks of COX-2 inhibitors and NSAIDs were increasingly recognized, their prescription decreased, but people still have pain and they still need their pain managed. And that is when we saw an increase in prescription of opioids. So there are unintended consequences of not having adequate pain management options for our patients. So in summary, pain is multifactorial in rheumatic diseases. We need to consider and manage other contributors to pain, such as sleep, depressive symptoms, coping skills, etc. We need to have realistic goals about symptoms and function. Zero pain is not the goal. And particularly for diseases like osteoarthritis, we need disease-modifying agents, and importantly, for all of our diseases, more pain management options, because we do need a multimodal approach. And ideally, we need a mechanism-based approach to management. We need to be able to phenotype what is contributing to their symptoms to better target therapy. And with that, I thank you, and I'm looking forward to having a robust discussion with Dr. Mees in addressing your questions. Thank you.